Well, good afternoon. Thank you for your invitation to share with you my experience in patients with keratoconus with IPCL. You do it? Should I do it?
If you make sure to speak into the microphones and make sure everybody can hear you.
Sorry.
Thank you. No problem.
It's too high for me. I have a pen drive with me. Do you want me to insert it here?
Do you have it on your laptop?
No, this is not my laptop. Okay, looks like.
If we don't have it ready, can we go to the next speaker, then come back? I want to make sure we try to finish on time.
We have it. Wait. Okay.
Perfect.
Okay. I have no financial interest to declare. I'm sure when we are talking about keratoconus, it comes to our mind a patient with usually male, young male, with high keratometry, thin cornea, and irregular astigmatism, but I'm not going to speak about those patients. I'm going to speak about the others. The ones who perform any additive cornea surgery, like cornea rings or keratoplasty, and they feel that the otherwise successful surgery is a failure because they cannot see. The main cause of this feeling is astigmatism. You, as a surgeon, you are very happy because you see the clarity and vision, but the patient says, and doctor, I perform a surgery, I cannot see. So we should try to find a treatment which is safe, predictable, and in only one surgery to match all their needs. Regarding these treatments, I put in bold the most important, but astigmatic keratotomy, if cylinder is very high, is not going to correct the full refraction. And laser refractive techniques are not recommended because there is a risk of endothelial decompensation. However, phakic IOL, for me, is the best option because it preserves the accommodation process. We do not touch cornea tissue. It has a kind of contact lens effect in terms of quality of vision, and we only do one surgery. And this lens is customized to implant always 0-180, and it can be customized regarding the cylinder. So this is a fact. We know that after penetrating keratoplasty, there is a chronic graft rejection process. Even if the graft is clear, there is a loss in the endothelial cell count. Cells become bigger, and there is high polymagatism. But after DALK, it resembles a normal endothelium. There are not too many papers published regarding phakic lenses after DALK or PK. Especially after PK, there is only case reports with complications. So even so, I think it's a good treatment for these eyes, but if we are facing these complications in normal eyes, we cannot afford an oversizing or high bold or low bold in a patient after keratoplasty because it means we will have to remove the lens and implant another one, and this can spoil the endothelium. So I chose this phakic IPCL because I had patients with high astigmatism, irregular cornea. They were not suitable for LASIK, and they were intolerant with contact lenses. The main test we performed was, of course, endothelial cell count and OCT anterior chamber to measure the angle-to-angle distance, because in these cases, sometimes white-to-white is a little bit tricky. But for me, it was very important to perform a best corrected vision test with contact lenses, because this is what we are going to explain the patient. This will be our target, okay? To improve 2-3 lines compared with spectacles before the surgery, and to reach, if possible, best corrected with contact lenses after the surgery. And of course, we are going to explain them it's a safe method. So let's start with the cases. The first one is a kind of poltergeist. I don't know if you know what is a poltergeist. It's something you see and you cannot explain. It's a male, 35 years old. According to him, He was treated with Intacs and ICL in 2014. But if you check the refraction, there is a -9 cylinder, which is matching keratometry. And two things, there is no central port, and there is a huge iridectomy. So it means either this is an old lens, or it's a plus lens. I don't know. Left eye, he performed penetrating keratoplasty, but even so the cylinder was very high, but his vision corrected was good. So we talked to the patient. We first removed ICL in right eye, then we wait for 1 month to let the eye heal. And then in the meantime, we implanted IPCL toric in his left eye, and then we implanted IPCL toric in right eye. The surprise was that after removing ICL in right eye, this was the refraction, -585. So I really don't know what was this ICL doing there. It was correcting nothing. After implantation, we discovered we implanted it upside down. This is not a common complication, but you can see the low bolt and the angles. Even though the vision was good for him and the pressure was normal, because these lenses have many holes to avoid high pressure. And in the lower image, you can see the angle after implanting the lens in the correct position. Uncorrected vision is good, both eyes separate and together. And these are life-changing surgeries for these patients, because this patient couldn't even drive. Another interesting patient, this is a male 17-year-old keratoconus. I performed ALK in 2018. 2 months later, he had a trauma. The Descemet's membrane was preserved, but he was resutured in this area where you have the arrow. And in the right eye, you can see he's wearing a broken scleral contact lens, even though his vision is very good, and he has papillary reaction in the upper eyelid. So in August, we performed DALK, and after removing the stitches, you can see there's 11.2 astigmatism diopters, and it's more important in the area that was resutured. This patient developed posterior cataract, polar cataract, so I performed the surgery. At that point, we were facing pandemics, I think, 4th wave, so I couldn't find a customized lens for him. This is the post-operative result, not so bad, but 6 months later, after posterior jaw capsulotomy, suddenly everything changed, the vision reduced, and the cylinder increased. So it means we have a tilting here. And we have to solve this, because this patient cannot see. In this case, the most predictable procedure was implanting toric IPCL. I recommend you to get maximum dilation, which is not the case. This IPCL size is 14. Perform a proper tunnel incision to avoid any stitches in the postoperative. Use tons of viscoelastic, because we must protect this endothelium. Big marks for alignment, because as you can see, there is a keratoplasty scar, and sometimes it's very difficult to orientate the lens, and administer Diamox at the end of the surgery. So this is the final result. We have our cornea with 11 diopters astigmatism. We have our tilted lens. You can see the posterior capsulotomy, and this is IPCL, correcting cornea and tilting. Uncorrected vision 0.7 with some halos at night, which he's happy with. Another patient, I'm not going to talk about the right eye, he's very happy with his right eye, but in left eye, we have the same problem as in our previous poltergeist. He implanted Intacs and ICL in 2004, but his vision is uncorrected 0.2, best corrected even with contact lenses 0.4. So these Intacs are not working, and the phakic lens is not working. We must remove all. But in these cases, my suggestion is to leave nothing to chance. You should count your cells. You should measure the depthness of the ring. So if we can remove the anterior cornea and the ring, we will have 100 microns area, and we can position our graph over it. And regarding the visual acuity, it will be the same as when you perform an ultra-thin DSEK. I'm not going to stop explaining you this DALK procedure, only telling you that in these cases there is a fibrous tissue surrounding the rings, and it's very important to dissect over and under the ring to remove it, okay? After removing the rings, we kind of polish the center of the cornea, And this is the final result. After 1 year, you can see in the upper image there is an 80 microns remaining stroma in the upper area, but the center is clear. So comparing pre-DALK with post-DALK, there is high astigmatism, but best corrected vision is better. Again, leave nothing to chance. Measure everything you have to measure. You can see now our cell count is 1333. And finally, 14 months later, his uncorrected vision is 0.8, improving to 0.9. This is the bold. I'm going to run. This is another patient. She came because of diplopia.
You can please wrap up. Thank you.
Yeah. And this is another interesting case. In this patient, we had PKP in right eye, DALK in left eye. So PKP means low endothelial cell count. DALK means normal endothelial cell count. We implanted IPCL, but there was a toxic anterior segment syndrome. You can see the pseudo-hypopion here. We increased the dose of cortisone, and he improved, and after 1 week, vision was 1.0. And the endothelial cell loss is not so important. This is a patient with epithelial dystrophy. So I cannot draw an important conclusion from my series because my numbers are not Indian numbers. But I think this IPCL is a precise, safe, and reversible method to try to treat high astigmatism after keratoplasty. Uncorrected vision equals best corrected with contacts, but you need to be an experienced surgeon. So it could be the missing final piece of keratoconus puzzle treatment. Thank you.
We're a little bit over time, but just very briefly, is this available in India? Does anybody here know, or do you know?
Yes. In fact, it comes from India.
This is actually manufactured in India?
Yeah, in
Excellent.
India and UK. I think they are going to open another factory in Egypt.
Ah, okay.
Yes.
What's that? Care group, okay.
It
Very
was
good.
approved in UAE 2 years ago.
Switch. Very good.